This conference will now be recorded.
All right, folks, so good evening. Thank you for coming to class this evening. And we are going to be reviewing and going over the respiratory system, okay? So we are going to be looking at chapter 17. The following week, we'll begin going into the digestive system. So tonight there, we're going to be looking at the respiratory system, the PowerPoint, as well as I have notes that I'm going to be, I didn't share the notes with you yet. I shared the PowerPoint with you all, but I'm going to share the notes after class. I am going to take the moment to, there we go, to also review this with you all, but first let's get into the PowerPoint and then we'll start looking at the notes. Okay, I'm going to press pause for mute for one moment. Okay, so let's look as far as the respiratory system and see the importance of this system as far as the ability to bring oxygen to the cells of our body and take away the waste gas, the CO2, and have that be exiting the body. We're going to be seeing the importance of the different pressure gradients and how having a difference between one area of the body and the atmosphere, different pressures, how that can affect how air enters and exits the body, as well as oxygen and CO2 exchanging between the lungs, as far as the lungs and the cardiovascular system, the blood, and as well as the cardiovascular system and the cells of the tissues internally. We'll see those two types of respiration and see how the importance of also different pressure gradients, different amounts of different levels of pressure from one area to another, allowing for movement of oxygen and CO2 in and out of the cardiovascular system and the cells and such. So pretty fascinating and interesting body system. When I think of the respiratory system as far as a system and the importance of it, I think of sadly the many patients that I've had over the years who have suffered with different types of respiratory illnesses and complications of from smoking and such. And so whether it's emphysema, chronic bronchitis, so we call that COPD, chronic obstructive pulmonary disease, or whether we're thinking of patients who I've seen over the years also who suffered with cancerous lesions in the lungs and the respiratory system or in the oral cavity as a result of chewing. Yeah, there's some pretty sad memories as far as that's concerned. I have many good memories of practice, but know that you're working with people who have illnesses and such, and to see them go through tough times as far as their ability to be able to breathe and such, it's as a result, in particular, emphysema, just tough stuff. And primarily, the majority of those patients that have emphysema, it's because of smoking, as a result of smoking. So, yeah, tough stuff. So let's look at the respiratory system and our ability to take in these gases and use them and properly perform functions within the body. So we'll be talking about the different anatomical structures. We'll be talking about gas exchange. We'll be talking about external and internal respiration. We'll be talking about pulmonary ventilation, which is the act of breathing, as well as we'll be looking at the interaction between the cardiovascular and the respiratory systems moving these gases. So here we'll see that we have, and let me make this a larger, I'm sorry. Here we go. So here we have, you can see so we have sagittal heads in the lab, and you're going to be looking at and going over and reviewing structures of the respiratory system as far as the nasal cavity and the conchae and the meatus here and the nares and oral cavity and the pharynx, which would be the throat. And know that the throat has 3 different regions, naso, oral, and laryngopharynx. And like I said, we'll talk about this in lab, and you'll see here how we have the voice box, your larynx, as well as trachea and the bronchi, and then the different types of bronchi present. And they go down to the point where we have these bronchioles, which have at their distal portion the alveoli, which is where gas exchange will occur between the alveoli of the lungs and you're not seeing here, but they are covered in capillaries. And so that interaction between the lungs and the cardiovascular system in the blood. Okay, so pretty interesting. You'll see here, and I'm not going to really take time going through this as well as we will be discussing this in lab. But you'll see here that we have, all right, here we go. We have the nasal cavity, we have the oral cavity, we have the naso, oro, and laryngopharynx, the throat, okay? Common pathway for food and air. And then you'll see here that we have the epiglottis, which will cover over and prevent any food or liquid entering into the trachea and the respiratory system. You'll see here that we have posterior to the trachea, we have the esophagus, and this is where food and liquids will end up going into the digestive system, further distal. So we'll, again, like I said, review all these structures as we're in the lab. And you'll see here, as far as these openings, these external and internal nares, these openings into the nasal cavity, the importance of these hairs that are present that line the vestibules, and the vestibule would be this area right in here, the vestibule. So think of the area where you can put your finger into your nostril. That would be the vestibule. Okay. And those coarse hairs will help to prevent any type of particulate matter from entering into your respiratory system. So you'll see here, as far as these turbinate bones, we would call them conchae, C-O-N-C-H-A-E. Again, I'll give you a list of terms that you'll have to know for the lab. And then we'll see here that there are olfactory receptors at the superior aspect of. So if you look here and see that, so cribriform plate, ethmoid bone, you'll see here that then you would have the, when we were looking at the special senses for smell, right, that the olfactory receptors would pass through those openings right in through in here and enter and be covered with very thick mucus in the superior aspect of the nasal cavity. And so you'll see here, as far as the warming and the moisturizing of air, so humidifying and the warming of air as it enters into the respiratory system can take place in the nasal cavity. Also contributing to our speech tone. Know that with the sinuses and such, you will have, if you have congestion involved and there's some type of infection, it'll affect the resonance of your voice as you speak, right? Because if you've got a cold, right, you'll, oh, hi, how you doing? Right? So it can affect your tone as you're speaking. We'll talk about phonation, speech and such, speech production. And I'll show you in the lab a video regarding the larynx, the voice box, your vocal cords, and we can actually view them as someone is singing and producing beautiful music. It's a pretty cool video. Like I said, I'll share that with you in the lab. So as far as the pharynx is concerned, those of us that are in the medical terminology class, we actually, one of the questions was a dual system structure or organ, and many picked the pharynx, the throat, because it does allow for its participation with the digestive system as well as the respiratory system, and a common pathway, we would say. The naso-oral and laryngopharynx, I talked about those earlier there, and just knowing that these are the sections of the pharynx, of the throat. There are many cartilage, and again in the lab there we'll see this, as far as cartilage is represented on models in blue, and these cartilages are important for the whole structure of the larynx, aka the voice box. Okay, and having soft tissue structures anchoring to these cartilages, and these cartilages being able to move and articulate with the vocal cords in order to produce speech, to produce sounds. Pretty neat. And we have here, as far as false and true vocal cords, that I will show you as far as on the There should be an image here. Yeah. So here you're looking at here a sagittal view of the larynx. You're seeing here the epiglottis. You're seeing here that there are these little sharp points, or these corniculate cartilage. We'll view this in the lab. You'll see a larger cartilage, which is the arytenoid cartilage, which actually then have connections to these vocal cords or vocal folds. Okay. And we'll see here also that you can see the cricoid cartilage is present, as well as the thyroid cartilage. So the thyroid cartilage is more superior, and you'll see the hyoid bone here. So you'll see also that there are soft tissue structures that anchor to the hyoid bone, which is a floating bone. And then distally here, you'll see the rings of the trachea. Okay. And the glottis. So let me just show you this here. So if this is the epiglottis, this is the covering of this area here of the respiratory system, and sound will move past through the true vocal cords, and there's going to be an opening there. It's called the glottis. So the epiglottis covers, it's upon the superior to and covering over of the glottis, which is an opening. So when we see here, when we see here this the glottis, just know that the glottis is an opening over the true vocal cords, aka vocal folds, and these are contributes to the ability to produce sound, and the epiglottis will again protect the respiratory system from liquids and solids entering in. So you'll see here also, this is a nice image. Let me, there we go, good. This is a nice view of the larynx and of the trachea. So you'll see here the trachea is distal. Here's the anterior, here's the posterior. Interesting how we have the tracheal rings go about 2/3. They don't form a full circle, so that there's actually a membranous portion of the trachea. And what would be posterior here, posterior to the trachea, would be the esophagus. And so know that it's not a full solid structure and really securing the trachea and giving support to the trachea. Only about, like I said, 2/3 around as far as those cartilaginous rings. And so this is important because imagine, you have substances going down your esophagus, and say there's something that's a little large going through there, and the membranous portion of the trachea is not hard tissue like the cartilage, and as such there's a little bit of movement that can go through there, and so it's not this solid mass that if you have something passing down into the esophagus that's maybe a little larger than it should be, it could get more easily stuck, if that makes sense, and the need for the Heimlich maneuver. So we'll look at the esophagus in the next chapter. Okay? So you'll see here, as far as the hyoid bone is concerned, again, a floating bone. We have these different structures, soft tissue structures that anchor to the bone, that anchor to the cartilages. Here's the thyroid cartilage. Here we have, again, this corniculate and the arytenoid cartilage. Again, the arytenoid cartilage connecting directly to those vocal folds. And then we see, as far as the thyroid cartilage, large in the anterior, the cricoid cartilage, smaller in the anterior, larger in the posterior. Okay. And so very important as far as the trachea is concerned, as far as allowing for the gases to enter into the lungs. You'll see here that pseudostratified epithelium with cilia and goblet cells are present in order to, the cilia will be covered in mucus. What's going to produce the mucus but the goblet cells, right? And these goblet cells, as well as the cilia, will be sticky and will hold on to particulate matter that's entering into the respiratory system to prevent it from entering into our lungs. Okay? And actually having a sweeping action of moving that mucus with particulate matter into the digestive system. Okay, patients who smoke, right? Patients who smoke really over time really anesthetize and really ruin the function of the pseudostratified cilia that are present, and really there's not that sweeping action. So what happens is that a patient goes to sleep, goes to bed, right? And they wake up in the morning, those that smoke, and they have this smoker's cough, right? It's producing mucus and just sounds terrible, right? What do they do in order to stop that coughing, right? Because the cilia are trying to get this material out of the respiratory system. They smoke. They start smoking a cigarette, and this in turn then helps to anesthetize the air. Those cilia, the goblet cells, and they're not going to function right, and then they stop coughing, but they've got all this particulate matter in their respiratory system. Not a good thing. Cough reflex stimulated by a foreign object, so anything entering into the respiratory system. The cough reflex, which would be located in the medulla oblongata. This would stimulate this reflex to automatically try to cough things out. Have you ever drank something real quick and it kind of went into the respiratory tract a little bit, into your trachea, past the epiglottis, and you just start coughing uncontrollably? It's because your body doesn't want that liquid material in the respiratory system. Okay? Here we go, as far as looking at the larynx, the voice box, as far as the trachea, the primary bronchi, and then we have secondary, tertiary bronchi, and then we have these bronchioles, which would then end in distally the alveoli. So here we have the alveoli. These little, they even make them color them in a purple because they do look like grapes, do they not? And this is where gas exchange occurs, and they are covered. They should be covered in the blood vessels, the capillaries that are covering each of these alveoli and allowing for gas exchange to occur. We call this external respiration when it takes place between the lungs and the cardiovascular system and the blood. And then we call when the blood is already oxygenated and there's exchange taking place at the cells of the tissues, we call that internal respiration. Okay. As a matter of fact, let's just take a look at that for a moment here, and let me just. So as far as these terms that I would like you to see right off the bat, and then we'll return to the PowerPoint. Ventilation, pulmonary ventilation, this is the act of breathing. Gases are entering in, gases are exiting, right? So breathe in, breathe out, inhalation, exhalation, inspiration, expiration. This is pulmonary ventilation. External respiration, this is when we have the gas exchange between the blood and the alveoli of the lungs, right? Those little, like, looks like little tiny grapes. That's where gas exchange is occurring. Oxygen from the lungs that we've taken in is entering into the blood. CO2 that's present within the blood is entering into the lungs and being released as far as via exhalation. Okay, so oxygen is loaded into the blood, CO2 is unloaded from the blood. Then we have this transport taking place, right, within the bloodstream via the plasma as well as the erythrocytes. And then internal respiration, the gas exchange between the cardiovascular system, the blood, and the cells of the tissues. So let's keep that in mind. Pulmonary ventilation, external respiration, internal respiration, the differences between, and the gas transport, what's taking place. We'll discuss that more in a few minutes. Okay. So here we're looking at the lobe, and again in the lab we will discuss as far as the different lobes and such, but you'll see here upper and lower lobe, but on the right side, upper, middle, and lower lobes. And what we're going to also view is that, so with this left side, you'll see this notch in through in here. So here's where the heart will be present, right? So there's a notch, and there's only two lobes on the left side because of the heart, and 3 lobes on the right side. Okay? And you'll see also that the secondary bronchi, there's a secondary bronchi for each of the lobes. So the primary bronchi, they branch off into secondary lobes, and a secondary lobe will send air to the upper lobe and the lower lobe. Then the tertiary bronchi will go to the different sections of each of the lobes. Okay? So with the right side, we have 1, 2, and 3 secondary bronchi, each going to the upper, middle, and lower lobe. And then we have the tertiary bronchi branching off into the sections of each of those lobes. And as a matter of fact, let me just show you an image. I'm going to go online for a moment here. And I would just like to show you here we go. So if you look at this there, and I'm just not really seeing very quickly. I just didn't get a chance to take a look at that and to see if I can find it for you, but I just want you to see how, all right. But if you see this image right here, actually, this one would be a little bit bigger. Okay. Okay. So here we're looking at, I don't know if I like that, to be honest. Yeah, here we go. This is what I like. Okay, good. So here we have the right lung, we have the left lung, and you're seeing that we have the two lobes, one lobe, two lobe, upper and lower, upper, you're seeing here, and then the middle and the lower. And what you're seeing is that each of these lobes is broken down into sections, okay, and it's in different colors and such, so that you're seeing that those tertiary bronchi will go to each of those sections of the lobes, okay? Here, good. Actually, I'm up here for a moment. So here, just as a review, you're seeing that we have the larynx, the voice box, we have here, and so here would be thyroid cartilage, here would be cricoid cartilage. Then we have the tracheal rings. Then we have primary bronchi, right here and right here. So right and left. We have secondary bronchi. We have secondary bronchi. Then we have tertiary bronchi, okay? So here we have the tertiary bronchi, and tertiary bronchi feeding and sending air to the different sections of the lobes. And really, it's interesting too when you think of it, it says bronchial tree, right? If we were to turn this upside down, right? If we were to turn it, flip it around, and have the trachea be the trunk, it does look like a tree. It truly does. Yeah. Something to keep in mind and help you to remember. And then those tertiary bronchi branch out into smaller tubular structures known as the bronchioles. And these are what are actually, bring it back up here for a second. These are what actually then are bringing the air to the individual alveoli. Okay? Covering of the lungs, we call the coverings the pleura. Right? So whether it's the parietal or the visceral pleura, the outer, the inner covering, so the visceral pleura has direct contact with the viscera, with the organ itself. Right? And the cavity would be the space between the parietal and visceral pleura, these connective tissue coverings, right? And having the term pleurisy, right, would be an inflammation, pleurisy, pleuritis, inflammation of the pleura. I said to you that before, the segments are supplied by each of the tertiary bronchi. And you should know this here, that the terminal bronchioles, now, and this will get a little confusing because you would think if something is terminal, like the terminal axon terminals, right, that would be the distal portion of that axon and its connection at the neuromuscular junction. But really, for the lungs, the terminal bronchioles are not the last bronchiole. It's really the most distal bronchiole. It's the respiratory bronchioles that are having then most distal, and then they would end with the alveoli present for the gas exchange to occur. Okay, so terminal bronchioles are not the most distal portion of the bronchioles and of the bronchial system. It's really the respiratory bronchioles will end at the alveoli. Okay, they end into the alveolar ducts, which then in turn the alveoli are surround those alveolar ducts. And this is where gas exchange occurs in the alveoli. Now, interesting term you're going to see here as far as this surfactant, covered in surfactant. So these alveoli, these bubbles of tissue, that's why I like to think of them, because they're one layer thick and they're very, um, term, they're, you know, you really, um, they're, they're susceptible to destruction, right? And destruction, by destruction, I mean, think of emphysema and patients that are having issues with the ability to breathe. What's going on is that they're really having an issue with exhalation, air leaving the lungs, because the walls of the tissue that separate and allow for these little alveoli, these little grape-like structures to have gas exchange, they get destroyed. They get um, really, just obliterated, to the point where there are areas of larger areas of the alveoli. They're larger, but there's less gas exchange occurring, and so that's a problem. Okay, they're covered in, so the alveoli inside are covered with surfactant. This is a lipid type structure, lipid type of liquid that reduces surface tension and allows for these little very small alveoli, these bubbles of tissue, to stay inflated. Without surfactant, so infants that are born premature and around the 6 month mark or earlier are having issues with a lack of an ability to produce surfactant, and so they really have issues with their ability to breathe on their own. That's one of the major issues with these infants that are born premature. Let's do this. I'm going to just stop for a moment, stop sharing, and I just want to see that everyone's okay, and do we have any questions at all? Covered a lot of information, talking a lot. Just want to make sure you're okay. Please, when we're in lab on Thursday, don't be afraid to ask questions, okay? All right, so I want to help you, and if you have any questions, please, jot them down, let me know, okay? Are we good? All right. I'll hide everyone, I'll share my screen, and we'll continue on. So I showed you here, as far as when I went to the notes, just the beginning of my notes, I showed you that we said pulmonary ventilation is AKA, also known as breathing. It's we're inhaling, we're exhaling. And it's this process that just never ends until we die, right? So inhalation, we could also say the word inspiration, right? Or exhalation, we can also say expiration. We could use those terms interchangeably. Okay. Know that inhalation, we're having contraction of the external intercostal muscles as well as the diaphragm. With exhalation, it's more of a passive process. So this is an active process. Exhalation is a passive process. The muscles are just relaxing, and air then will exit the body. And we'll talk more about that in a moment. But just know that inhalation is an active process. There's contraction taking place. Exhalation, a passive process. Now know that we can incorporate more muscles for forced inhalation and forced exhalation. But just on a tidal breathing, we're just having contraction. Passive would be for exhalation, and active would be for inhalation. And I'm going to talk about now. So you'll see here, you just see where it says pressure. Pressure decreases in the lungs, air rushes in. Pressure increases in the lungs, air rushes out. Oh, okay, what does that mean? Well, I'm going to finish this here for a moment, and I'm going to go back to my notes. This one, another one, there we go, okay. So, scroll down here a bit on my notes, and you'll see here it says volume and pressure. So volume and pressure are inversely proportional, meaning that if one is high, the other is low. And if the one is high, the other is low. So, so say volume is here, volume is high, pressure is low. If pressure is high, volume is low, inversely proportional, okay? So here's the thing with Boyle's law, okay? And again, you'll see here it says assuming constant temperature and a closed environment. And so what we're looking here is a closed environment, okay? So representing the lungs, but just it's a container. and it's a container that we can change the volume, okay? So if we have a higher volume, there will be a lower pressure, okay? So as the volume increases, the pressure decreases. This is a key, important, crucial, really point to understand as far as pulmonary ventilation is concerned. Okay? So as volume increases, pressure decreases. As volume decreases, pressure increases. Again, we said volume and pressure inversely proportional. Okay, so it's important to keep that in mind. So as my external intercostals and my diaphragm contract, my lungs expand, and the volume present increases. So if the volume increases, what happens to the pressure? It decreases. And this in turn will allow for then air to go from a higher pressure in the atmosphere. So the atmospheric pressure, the air that we breathe, it's higher than what's present in my lungs because the pressure decreases within my lungs. So air will go from high pressure to low pressure. So it'll enter into my respiratory system, into my lungs. Okay, so it's not so much that I'm doing this. Now, do people do that? Absolutely. And can you do that? Especially, you know, hey, you've been exercising, or unfortunately, maybe if you have issues with asthma or emphysema or other types of respiratory issues, then you would forcibly, you know, inhale, inspire and expire, inhale, exhale. But just normal breathing, regular tidal breathing, my external intercostals contract, my diaphragm contracts. So the diaphragm is like this. When it contracts, it flattens. So it's dome shaped, relax, contracts, relax, contracts, okay? So when the diaphragm contracts, it flattens, okay? Increasing the volume, decreasing the pressure in the atmosphere is greater, so it enters into the lungs. Now, when the muscles relax, right? The muscles relax, the volume decreases. As a result, if the volume decreases, what happens to the pressure? It's what? It's inversely proportional, so it increases, and so then the air from in my lungs exits and goes out, high pressure to the atmosphere, which is low pressure. That's exhalation, okay? So active process, passive process. Contraction of muscles, relaxation of muscles. Now again, if I can forcibly exhale, and then I would be incorporating other muscles involved in order to do that, but that would be an active process. But if I'm just normal breathing, active inhalation, passive exhalation, okay? Here, I want to show you also, should have, here we go. So this is also in the notes, okay? So again, Boyle's law, pressure and volume are inversely proportional. One's high, the other's low. The other's high, the other one's low. Take turns. So in the case of inspiration or inhalation, contraction of diaphragm, see the diaphragm, it flattens, and also intercostal muscles. They are the muscles between the ribs. Those muscles, the external intercostals, they contract, the diaphragm contracts, the volume increases in the lungs, the pressure as such will decrease. It'll be less than what the atmosphere is. So what's going to happen? Upon inspiration, air enters into the respiratory system. It goes from high pressure to low pressure. How about leaving the lungs? Well, relaxation of the diaphragm, right? Relaxation of the intercostal muscles between the ribs. The pressure increases, so the volume decreases, the pressure increases, greater than the atmospheric pressure, air exits the body upon expiration, and there we have it. Okay, so that's pulmonary ventilation. Okay, and here we go. As far as that surfactant I mentioned to you earlier, there, lipid molecule coats the gas-exposed alveolar surface, the inner portion of those little grape structures where gas exchange occurs. Okay? And really, oxygen and CO2, they move as a result of diffusion. So external respiration, internal respiration, there's movement of oxygen and CO2 as a result of diffusion. Okay. Okay. So here we have, as far as, again, just a review of the pulmonary ventilation, completely a mechanical process that depends on volume changes in the thoracic cavity. Volume changes lead to pressure changes, which lead to flow of gases to equalize pressure. See that? So understand this. If the pressure in my lungs and the atmosphere are the same, will gas move? No, it will not. Unless we forcibly, you understand? If the pressure is equal in my lungs as it is in the atmosphere, no movement of gases. Okay, you need to know that also. Right, and so I've just given you, as far as an explanation of inspiration and expiration, or inhalation, exhalation. Okay, you can review that on your own. That's just what I've been talking about this past period of time. Now, the external respiration, I said, it's the movement of oxygen, right, being loaded into the blood. So the oxygen in the alveoli of the lungs leaves the lungs, enters into the blood, those capillaries surrounding the alveoli. It's loaded into the blood. The alveoli always has more oxygen than the blood. So then the oxygen moves by diffusion toward the area of lower concentration. So within the lungs, high concentration. In the blood, low concentration. Movement from high to low, it's diffusion, is it not? So that will be diffusion into the blood. The pulmonary capillary blood it has more oxygen, right? It becomes oxygenated, it becomes oxygen rich. I've used that word before in the lab. CO2, on the other hand, moves in the opposite direction, right? CO2 is unloaded out of the cardiovascular system, out of the blood, of the capillaries, and into the alveoli, which will in turn exhale that, and that will exit the body. Okay. Now, the gas transport. So the gas is transported in the blood, and know that oxygen primarily is transported by the hemoglobin in the erythrocytes. Okay, a small amount is dissolved into the plasma, the liquid portion of the blood, whereas CO2 primarily, CO2 is traveling as CO2, like about 20 some odd percent, 23% in the blood, in the plasma, and a portion of it then would also be in the actual carried by the hemoglobin, and then primarily it's as traveling in the plasma, the liquid portion, as bicarbonate, okay, as a bicarbonate ion, HCO3 negative, right? It's an anion, okay. And so what will happen is that when it comes time for the CO2 to be leaving the cardiovascular system, that bicarbonate then will interact with the erythrocyte and become CO2, and that all the CO2 will then leave the blood. Look at here where it says, for carbon dioxide to diffuse out of the blood into the alveoli, the lungs, must be released from its bicarbonate form, like I just said, right? So bicarbonate will enter the red blood cell, combine with hydrogen ions, form carbonic acid, H2CO3. Carbonic acid, this H2CO3 will split and form H2O and CO2. Okay? And CO2 will then diffuse from the blood into the alveoli. Okay? So this is what's going on as far as the gas transport. And I mentioned to you earlier there about the external respiration. Now, internal respiration, this is where we have this exchange between the cardiovascular system and the cells of the tissues. Exchange of gases between the body cells and the blood. CO2 will diffuse into CO2 will diffuse out of the cells, out of the tissues in the cells, and into the blood, so that CO2 is being loaded right into the blood, and then the oxygen is going to be unloaded into the cells and tissues, right? And that's internal respiration. That's stop sharing for a moment here and just see. Does anybody have any questions or any comments? Okay. We'll go a few more minutes and then we'll take like a 3-minute break and then we'll come back and finish up, but let's go a few more minutes, okay? Back to the PowerPoint here. All right. That. So here you're just seeing, this is just an image showing you as far as the what's taking place as far as for when contraction of musculature and the increase in, so if we have during inhalation, the diaphragm contracts, pulls downward, right? So it flattens, causing the thoracic cavity to expand, increasing the volume of the lungs, decreasing the pressure. This is inhalation to the left. Expiration or exhalation, musculature relaxes, passive process. So the muscle, the diaphragm that was flattened will now relax and become this dome-shaped muscle. And as a result, the volume decreases, the pressure increases, and air exits the respiratory system, exits the lungs. We talked about this already a few times, external and internal respiration. And here again, just a nice image just showing you structures of the respiratory system. And here you're just seeing, I want to point this out since the heart is present here. So you
Dr.
see,
Brown,
yes, go ahead.
your screen share isn't on.
Oh, I'm sorry. I apologize.
Okay.
Yeah. Oh man. Let's sorry. I'm sorry. Thank you for saying something. Let me come back here then. This is probably where I left off. Did you not see this before then? This image? Probably?
No.
Yeah. Okay. So I'm sorry I talked you through it, but I didn't show it to you. So this image here on the left, you're seeing inhalation. Here you're seeing exhalation. And inhalation, you're seeing the contraction, the flattening of the diaphragm. You're not seeing, they're not showing you the intercostal muscles because they want to show you the lung. But you'll see here that there's an increase in volume, a decrease in pressure. So air will rush in. The pressure goes from high to low. So high atmospheric pressure, lower pressure within the lungs, so the air rushes in. As far as exhalation, here you have the dome-shaped diaphragm relaxes, the volume decreases, the pressure increases, high pressure, low pressure in the atmosphere, so high pressure to low, air is exiting from the lungs. Like I said, we've talked about internal and external respiration. And here again, just a nice image as a review. And here we're just showing as far as what's taking place as far as external and internal respiration. So the partial pressure of a gas. So this is just the matter of, let me go back to my image here that I have here. And so here you're seeing as far as pressures that they're giving you as far as numbers just within the lungs, right, within the lungs and the atmosphere. But there's also then this pressure, partial pressure, that we're going to be looking at as far as in the tissues and such. So let's go back to this image here and show you that dependent upon whether you're in the blood or in the tissue, in the cell here of the tissue, or whether you're in the alveoli or the blood, there's a pressure gradient that takes place. So as far as the lungs are concerned, right, the alveoli have a high oxygen concentration, right? The oxygen concentration in the blood, low. So we're diffusing from high to low. How about CO2? High in the blood, low in the lungs, so it goes from high to low. Just vice versa as far as with internal respiration and the blood and the cells of the tissues, okay? So important to get that partial pressure, it's the amount of pressure gas contributes to total pressure and directly proportional to the concentration of the gases present. And know that the gases that are present, it's not just oxygen and CO2. Primarily, there's a high concentration of nitrogen gas present within the air that we breathe, okay? So oxygen They're in the 20 some odd percentile or so. Just remembering off the top of my head, yeah, it's around that in comparison to like a 70 percentile regarding the nitrogen. Right? And this is important too. Gas diffuses from high partial pressure to low partial pressure. So it's a diffusion. It's going from some place of high pressure, high concentration, to low pressure, low concentration. That movement, that would be a diffusion. Now, this right here, as far as capacities and volumes, okay? So I have on another, and I'm going to show you on my notes, the second part of the notes, that I have like a chart and I think that it might be a little bit more helpful to you. Know that right here where it says total lung capacity, it's the volume of gas in the lungs at the end of maximum inspiration. Total lung capacity, that's the volume of gas in the lungs at the end of maximum inspiration, inhalation. Okay. Okay. Let's minimize this. I believe right now what we'll do is we'll take a 3-minute break or so, and then I'm going to put up for you here, so here are the volumes and the capacities and such. So I want to just show this to you after we come back from a 3-minute break, okay? So let's do that there. Yeah. All right, folks, so I will put up, put this, no, I'll put, you know what I'm going to put up? I'm going to put this up for the next 3 minutes, just as a reminder. So for 3 minutes there, we'll come back at 5:28 or so. So I'll be right back, folks. Minutes. All right, folks, back there, and thank you for a little break there for a moment. And just so I want to just review with you all just regarding that. So this week and next week, this Thursday and next Thursday, both groups will be on campus, and I really do believe that we can meet for the rest of the semester on campus, as long as that's going to be available to us, as a result of the class size being reduced in number. And so we can have both groups meet at the same time. And so we'll have them for the rest of the semester, as long as we can, have you all come into the lab on each Thursday, okay? All right, so if there's an issue, just let me know. But other than that, we'll be fine with that. So know that on the 19th, again, that's when we will have our test number 3. So here we go as far as looking at, excuse me, volumes. And so when we think of the tide, so tidal volume, I've mentioned this as far as tidal breathing there. So pulmonary ventilation, normal breathing, this is just when we breathe in, we breathe out. Breathe in, we breathe out. That's approximately 500 milliliters, okay, as far as the amount that fills our lungs as far as this tidal volume. Inspiratory reserve, expiratory reserve, these are air that's forcibly taken in over the tidal volume or after tidal expiration, okay? Residual volume, so when you think of the residue, when you think of residual, air remaining after expiration, okay? So there's still air present within the lungs. So allows gas exchange to go on continuously, even between breaths, and keep the alveoli inflated, okay? And again, what contributes to this the ability for the alveoli to keep inflated, having this surfactant present, okay? You'll see here this dead space volume, air that remains in the conducting zone and never reaches the alveoli. So think about this for a moment. So all the air that's present within the respiratory system, not all of it is involved in gas exchange. Really, where do we say gas exchange occurs? At the alveoli. So if the air is still present within the respiratory system, but present within the trachea, present within the bronchi, the bronchioles, but it's not present in the alveoli, it's not gas exchange, so that would be conducting zone of the respiratory system. Excuse me. And you'll see here as far as, so I want to show you this non-respiratory air or gas movements, right? So coughing and sneezing, and I just did that, clearing the lungs of debris, crying, laughing, hiccuping, yawning. These are all types of movement of air that you really primarily don't have any control over. I wanted to show you this. And again, this is on the note packet here that I will be sharing with you all. So this is just giving you an idea regarding the different volumes, and the volumes, combinations of the volumes create the capacities, okay? And total lung capacity, it's all of the volumes. All the volumes is the total lung capacity. Okay, as far as, so this is important to see as far as respiratory sounds are concerned. So know that the sounds that can be heard via the stethoscope, so upon auscultation, that term auscultation, the ability to hear using our stethoscope. And we're auscultating and listening to the sounds that are present. So bronchial sounds are produced by air rushing through bronchial. When you think bronchial, think large passageways, such as the trachea and the bronchi. Vesicular, think of the soft sounds of the air filling the alveoli. Okay? And why would this be important? Because if a patient has pneumonia, has some other issues going on with their lungs, we can tell the difference between whether they're clear or they're not clear. Now, neural regulation, this is important as far as the nervous system is concerned. And know that the medulla oblongata, this is one of the chief primary areas present within the brainstem that's going to be controlling the respiratory rate. and the rhythm, okay? So, and the pons will work in conjunction with the medulla oblongata. Remember, the pons is superior and anterior, looking like those oval structures of the midbrain. So pons, medulla oblongata, these are really what are working to control the rate and depth of respiration. The term eupnea, right? Eupnea, EU, that prefix there is for normal, represents normal. So the euthyroid would be a normal thyroid. So eupnea would be this respirations that are taking place. Between 12 and 15 is a normal respiratory rate. And you'll see here as far as that, we can have changes and differences. So newborns, 40 to 80 respirations per minute, right? Infants at 30. And so the changes occurred. Rate often increases somewhat with old age. So if eupnea is a normal rate, so then hyperpnea, increased respiratory rate. Hyper, right, increase. So increased respiratory rate, often due to extra oxygen needs. So how about if we're exercising? That would be good and normal, right? As far as chemical factors, so oxygen and CO2 levels, there are chemoreceptors present in order to determine what those levels are. And know that really CO2, carbon dioxide levels, these are the levels that are going to be what are the trigger for respiration, okay? So in other words, if I'm holding my breath, if I'm holding my breath outside, just sitting here and holding my breath, or I go deep in the water, right, and hold my breath, it's the buildup of CO2 levels in my body, not the decrease of oxygen levels, that are the trigger to want me to allow for me to have that desire to breathe. That's it. So CO2, increased CO2 levels, that's the trigger. With a patient who has like emphysema, then it would be oxygen levels. But a patient that has normal respiratory system, it's the increase in CO2 that's the trigger for breathing. Rhinitis, laryngitis. So these are inflammatory conditions of the nasal mucosa and of the larynx, so the vocal folds. Smoking, right? I mentioned to you this earlier, as far as inhibiting and really ultimately will lead to the destruction of the cilia. Folks, take a look at these lungs here, as far as lungs that are full of tar and particulate matter to the left, and those that are not. Now, again, so the issue is that, so these, I mean, not to be silly or anything, but just know that, you know, they're both came from cadavers, so they both came from dead bodies. But just as far as, it wasn't a lung issue that killed the patient, it was more of some other type of issue. But you'll see here as far as healthy lungs from a non-smoker and from a smoker. Okay. Here's just some information regarding the Heimlich maneuver. Has anyone ever had to okay, are we okay now? We're all, I stopped sharing my screen, or and I'm just bringing you all out for a moment. I wanted to know, has anybody ever had to do the Heimlich maneuver? Nobody? Okay. I've never had to do it myself, but fortunately not. Yeah. Yeah. Oh, okay. Shauna. Wow. That must have been scary. Absolutely. Yep. Especially with little ones. Yeah. So commonly, you know, with little ones, they're eating, they're just not chewing right, and swallow, and you know, things happen, and it's pretty scary. Absolutely. We've had close calls, but never had to actually do the Heimlich maneuver. How about like some back thrusts and such? That's also appropriate. Jamie, did you have some comment? No? Okay. All right. So, all right, I'm going to hide everyone and we'll continue on. So here you'll see the Heimlich maneuver.
Sorry.
Yes. Yes, go on. I'm sorry. Did someone have a comment or a question? We're good? Okay. I thought
They turned it on by accident.
what's that?
I think somebody turned their mic on by
Oh,
accident.
okay. Yeah, no worries. Yeah, no problem at all. No problem. All right, let me hide everyone. I'll share my screen again. Just a moment there. Oh, okay, Jamie, no problem. So here we have this image of the Heimlich maneuver, and so you can review that on your own. Very important to do. Repeat several times until the choking object comes loose. If the patient can speak, then you would encourage them to cough on their own first. So if they can speak, that means that there's some air getting through, and so let them cough for sure. But if they can't speak and they're choking, yeah, do the Heimlich maneuver, do the back thrust. All can be very helpful. Okay. All right, so you see here, I've mentioned this term to you earlier there as far as COPD is concerned, right? Chronic obstructive pulmonary disease. And so you'll see here, as far as it's a matter of a combination of chronic bronchitis and emphysema, okay? So I like this image right here. You'll see regarding chronic bronchitis, you're seeing here that there's an inflammation, excess, and the itis, the suffix gives that away. And gives you insight as far as that's concerned. Excess mucus and muscle constriction, right? So you see here a nice large lumen, very constricted lumen with increased mucus production. Here we have as far as emphysema, healthy. See all those nice little alveolar sacs. Alveolar membrane is degraded, it's worn away, and so there's actually larger spaces, less gas exchange, a problem. You'll have weight loss, wheezing, chronic dyspnea, difficulty breathing, cough and sputum, this excess mucus production, and chest tightness. Okay? You'll see here with, as far as emphysema is concerned, also I mentioned to you as far as the ability to actually exhale and get the air out of the lungs. So you'll see here there's an overinflation of the lungs leading to a barrel chest. Okay? Patients with emphysema. And again, many times the etiology is that the patient was a smoker at one time. Lung cancers, there are different types of cancers as far as squamous cell, adenocarcinoma, small cell carcinoma. These are also increased incidence as a result of smoking, right? And lung cancer is very aggressive, metastasizes, spreads throughout the body. Sadly, in my family, my wife's family, we've had loved ones who are smokers and have died as a result of lung cancer. And I know this hits many people in our country and throughout the world. Lung cancer is a horrible thing to die from, it truly is. As far as this infant respiratory distress syndrome, this is a surfactant issue. So not having the surfactant being produced or not or inadequate or none at all can lead to the fact that see here where it says the premature infants have issues with their lungs staying inflated because of the lack of surfactant in the alveoli. And so we're looking at, surfactant forming 28 to 30 weeks. 40 weeks is when we deliver the baby, between 37 and 40. So in that stage there, that's an issue, and they'll give steroids and different medications in order to speed up the production, speed up the actual development of the lungs in order to then produce the surfactant. Okay. I also have on my other, let me see here, on note 1, and I didn't mention this to you. Yeah, so there are it'll come to me. I'm thinking of the specific types of cells that are present that will actually produce the surfactant, and it's not coming to me right at the moment, but it'll come to me. Excuse me. Sudden infant death syndrome, SIDS. This is something where we're not really understanding what's going on with a parent healthy baby, stop breathing and dies during their sleep. Thinking something going on regarding the nervous system, also possible heart rhythm abnormalities. There's really, SIDS is I have not had a patient have a child die of SIDS, but many do throughout each year and such. And so, trying to figure out and understand the etiology behind it can sometimes be very difficult. Asthma, see here, as far as this just gives you a nice graphic here regarding, so normal bronchial tube, and here would be an inflamed bronchial tube as a result of an asthmatic, and you'll see that there's inflammation present, swelling, edema, mucus production, excess, and there's also the musculature contracts of the smooth muscle of the bronchi, and as a result, this can affect the movement of air in the respiratory system and affect their ability to ventilate as well as to respirate. That's it as far as these notes. Okay. All right, folks. So we have covered a lot of information in a very abbreviated period of time. I'm going to press stop.